Okay, so as you can see, I've highlighted a detailed history just for the purposes of illustration. For now, since the book doesn't go over the 97 guidelines, I'm going to go over those briefly. Basically, things are termed in bullets. Down here we have the comprehensive exam. Anything that is worthy of a bullet is on this sheet right here. The one thing that providers will complain about, or not necessarily complain about, but be in shock over, is that bowel sounds are not worthy of a bullet. That will generate a little bit of stress on their part, but so be it. Each one of these things, if you see it mentioned, is considered a bullet, or if it's implied. The buckets you can have are less than 6, 6 to 11, or greater than 11. This 2 and 9 does not mean 18. It means that you have to have 2 bullets in 9 of these systems. There are, I believe, 14 systems, but GU male and GU female obviously can't be in the same exam. Over here, this grid right here represents musculoskeletal. As you can see, you can rack up 24 bullets just by doing everything in musculoskeletal. So it's kind of a rich field of bullets, as we like to call it. The book teaches you how to do the 95 guidelines. Now the 95 guidelines use what are called organ systems. Organ systems are the same as a review of systems, except that these last two that are starred, they're combined. Okay, so if you see in the exam portion where it mentions the vitals and the patient is in no acute distress, that would be constitutional. Okay. Anything that's mentioned in terms of organ systems, you can check off. Body areas are listed down here where it says body areas include head or face, neck, chest, abdomen, genitals or groin or buttocks, back, and extremities. Okay? That's it for the exam. It's not terribly complicated. For purposes of what we're going to do, we're going to say that somebody did a real minimal exam, and we're going to say that it ended up being just a problem-focused exam, and we saw just the vitals. Okay, so that means it'll be problem-focused. Make it a little off color here to see our subtotal lines. Okay, now we're going to get into medical decision making. Medical decision making is something that takes a little while to grasp. What it tries to do is kind of capture clinical intuition on the part of the provider. So we have 3 sections: diagnosis points, data points, and a risk table. Now this risk table, as I said in the email, is a very much reduced risk table. It's for family practice. Family practice will not see a high-risk patient. Very, very, very rarely. Diagnosis points does not mean the number of diagnoses. It basically falls into 2 categories: new and follow-up or chronic. Now the way that you total this is that new, which means it's new to the provider, if there's no workup, so if there's no imaging, labs, referrals, or one other thing that I will remember in a little bit, studies, like EKGs, EEGs, things like that, that's considered workup. So if somebody comes in with a cold, okay, that's going to be 3 points right off the bat, even if the physician does nothing for the patient. Okay. If they come in for a chronic problem, you get 1 point for each chronic problem or follow-up. If it's not at goal, which is up to the provider, then you get an additional point. Typically they'll use words like not stable or not controlled. That will tip you off that they get an additional diagnosis point for that chronic condition. Notice that if a patient comes in for a common cold, it's 3 points. If a patient comes in for management of their chronic diabetes, hypertension, hyperlipidemia, it is the same amount of diagnosis points. You are weighed very heavily towards new problems. So we're going to say that somebody comes in for a cold. Data is not used much in a physician's office, family practice office. And the reason is because you would have to do a lot to do data. Okay, if you order labs, that's 1 point. Even if you order 16 labs, that's still only 1 data point. If you order 14 x-ray views, that's 1 data point. Now the only exception to that is that there's this thing called being overread. So if a physician takes an x-ray in the office and they look at the film, give their clinical impression, and then also reference the radiologist's report, that's worth 2 points. Think of it as 1 point for the film and 1 point for the radiology report. So we're going to say that the person who came in for their chronic cold didn't have anything, and so we get 0 points for that. Okay, risk. Now typically, remember how I say that the lowest guy wins. With the risk table down here, that is not true. It's the highest guy that wins. So you have presenting problems, diagnostic procedures, and management options. If somebody comes in for, say, a fractured ankle, that is an acute, uncomplicated illness. If a physician prescribes them Vicodin, that is prescription drug management. It now bumps it up to moderate risk. So be aware of this risk table. These are the ones that are most commonly used. There's a much more comprehensive risk table in your book, and I would recommend you use that for the exercises, but for everyday work, this one will probably be okay. So we're going to say that this person comes in and the physician sees them, and we just say that we're going to send them home to use acetaminophen over the counter to clear up their stuffy nose. Okay? Notice, unlike the HPI, the medical decision making says 2/3. That means you get to drop one. Well, if the lowest guy wins, why not drop the lowest so that way we can bump it up? So that's exactly what we do, is we cross out data. Now the lowest guy wins. We get low complexity. Okay? Now, this is how you evaluate the documentation. For the exam, I will already give you these different levels. Your job will be to use this portion of it, or out of the CPT book, which is what this is modeled after. So if we copy these over, we have a detailed history. We have a problem-focused exam. And we have low complexity. Okay, remember that the lowest guy wins, but we've also got this established 2/3. If we drop the exam, the lowest guy would make this a 99213. And that is how you get an E&M code. Yes, it is very complicated. It gets even more complicated because you'll see over here these new patient and for consults. New patient and consults, if you look at the CPT book, share the same guidelines. But you'll notice that they have different box structure than what the established patients do. Hospital and observation have different box structures, as well as outpatient and all the other E&M codes. So you'll need to look at that carefully. Just remember that it says you only need 2 of the 3 components. Whichever one is lowest you can cross off.